So today we are going to talk about MI, and it's a very important topic when it comes to pathology and medicine. So first, we're going to discuss about the cardiac enzymes, which are very important, and they are regularly being asked. And the enzymes which are elevated post MI are troponin, T, and I, and there are various other enzymes also. But most sensitive and specific enzyme elevated post MI is troponins, and again, if they are asking about that most common enzyme which is elevated and which can be checked in 8 to 10 days window period when there is a reinfarction or there is a repeated attack of MI, then answer would be CPKMB. And okay, because it usually disappears in 2 to 3 days, and if there is again an attack, if there is a repeated attack, then it can be detected by CPKMB. Then the good test to do that would be CPKMB, not troponins. But troponins will remain in the blood elevated till 10 to 14 days period, especially when it comes to troponin T, and 7 to 10 days for troponin I. So basically, if they are like rising, they remain elevated till 2 to 3, like you can say that 2 weeks time basically. So if you want to check in that 8 to 10 days period that there is a reinfarction or repeated attack, then we can check it by CPKMB, not troponins. Even if the troponins is given as an option, the best answer would be in that case would be CPKMB, that is creatine phosphokinase. And this enzyme basically disappears in 2 to 3 days and it gets elevated. So I'll be talking about like there is a timeline for each and every enzyme. There is the CPKMB which gets elevated in basically 4 to 8 hours, okay, and then it gets like peak high in 48 hours, and then it disappears in 2 to 3 days. So it's all like enzymes are there, like TI, then there is LDH, then there is AST, which have this period where it begins to be seen in the blood. Then there is a peak high for these enzymes in the blood, and then there is a time where they get disappeared. So I'll just for the enzymes, you just need to remember that the timeline where it gets disappeared, or okay, that is more important. And more important is that when there is a fresh attack, what enzymes can be looked for in the blood, that are troponins, and if there is a repeated attack, that's CPKM. And basic things you need to know around these enzymes. So what the mnemonic is when the timeline to which these enzymes get disappeared in the blood, that is more important. So CPKMB disappears in 2 to 3 days. You will know about TNI, troponin TNI will be like it will get disappeared from the blood, that is in 7 to 10 days, and then 10 to 14 days for troponin T, and LDH and AST. And there is also an enzyme which is the earliest marker of MI, that is myoglobulin, that gets elevated in 30 minutes to 2 hour period. And that also gets you can remember by this mnemonic, that is my car lit up with enzymes. Why I'm adding enzymes? So that you can remember, I'm talking about cardiac enzymes here. So my means myoglobulin, and myoglobulin usually disappears in 10 to 12 hours, okay. 10 to 12 hours. Then CPKMB, it disappears in 2 to 3 days. AST, 4 to 5 days. LDH, 10 days. I and T, 7 to 10 days. Troponin T is 10 to 14 days. So we basically, the importance is like even if you cannot remember the whole timeline for these enzymes, like you just need to remember the the important enzymes which need to be tested after MI, and what are the enzymes can be tested for reinfarction. And that CPKMB is very important because it's constantly and regularly being asked, and also it's equally clinically significant kind of an enzyme which is a marker when there is a kind of a reinfarction. Okay, in 8 to 10 days period you need to check out because it disappears in 2 to 3 days, and it can be seen in the blood in 4 to 8 hours, but it disappears in 2 to 3 days. It's very important. So okay, this one is very important. LDH, okay, LDH will remain in the blood till 10 days. Okay, and talking about INT will be like, you know, that it will be 10 to 14 days and 7 to 10 days for troponin I. And myoglobulin will remain, it will be the earliest biomarker, but it will just disappear from the blood in 10 to 12 hours. And then there is this AST and SGOT, it will also disappear in 4 to 5 days. So the disappearance of this enzyme is very important. So for that, this mnemonic, with this mnemonic you can remember it. And then we'll talk about this the little about medicine part also, what all questions can be asked. Now this was about path where these enzymes are asked, like what kind of enzymes are elevated, those things are asked in path. But in medicine part they can be asking about this the MIs, which are like what is the most common MI to be seen, and the most common MI is anterior wall MI. And after that, you know that there are various other MIs also. There is inferior wall or posterior wall MI, green area. With the green area you can see that has been involved in those cases, and the lateral infarct. And then there is an anterior wall MI, and there is a septal MIs. So among all, the anterior wall MI are the most commonest, one thing. Second thing is the inferior wall or the posterior wall MI. Now how we can like see these MI, the basic thing, the clinical finding which we can see in the ECG, the ST segment elevation. Okay, but in that also, let me just okay. So in ST segment elevation also, in fully evolved cases, and when there is an old infarction that has been like there was an old infarction or there was an old attack of MI, you will not be able to appreciate that ST segment elevation in those cases. In those cases, you will be able to see only the Q waves on ECG that are pathological, and with that you can understand that there was a previous MI attack. And also in early, in fresh attack cases only, in acute MI cases only, you will be able to appreciate that ST segment elevation. First, what is this ST segment elevation? So if we know that there is like ECG, if we like see that there's a P wave, there is a this PR interval, there's this Q wave, QR. Okay, so we know how a normal ECG looks like. Okay, there is a P wave, there is QRS, and there is T wave. So, so what happens is, in this case, this is a J point. So the J point is very significant over here. We need to know what is the J point first. J point is the point of where the S segment, QRS segment, or you can say that the QRS peak ends. Okay, and this ST segment begins. That is the J point. Okay, and the J point is clinically significant. Why? Because if this ST segment elevation is above this J point, or this S crosses the J point, then only we can say that there is a ST segment elevation, or there is ST elevation MI. Okay, now okay, what is this ST segment? The distance between this point, you can say that, whereas this S end and the beginning of the T wave. Okay, so the distance between the S point ending and the T wave beginning, that is the distance which is known as ST segment. And that ST segment, if it is crossing this line, that is the J point, and it is getting elevated above it, then that is called as an ST segment elevation. So this J point is clinically significant when you have to see that ST segment elevation. One thing. Second thing, and there are there are other cases of chest pain also, like unstable angina. There is non-ST segment elevation MIs also. There is NSTEMI, okay, and there is ST segment elevation MI. So in unstable angina, just a second, just. So there are three types of angina. There's a unstable angina, there is this stable one, and there is a variant also known as Prinzmetal kind of an angina. In all these three cases, okay, only in one case, that is a variant angina, the cardiac enzymes is elevated, and in unstable and stable angina there is a chest discomfort, and the cardiac enzymes in these two cases are not elevated. And in unstable angina there is a pain or the chest discomfort is there, which is at rest. Okay, and in stable angina the chest discomfort is there in exertion, little exertion, and it is relieved by rest. Okay, and the cardiac enzymes are normal. Here also it is normal. And in variant enzyme, the cardiac enzymes are elevated, and the pain and all the chest discomfort is there in the rest. So basically, you can see this the changes in the cardiac enzymes post MI, but in the cases of chest discomfort, the cardiac enzymes are usually not elevated. And plus there is this NSTEMI also, where there is non-ST segment elevation MI, and there is this STEMI also. That is the ST segment elevation MI. Now in this case we all know that NSTEMI is due to partial obstruction, and STEMI is due to complete obstruction of the coronary circulation, and therefore it is causing the ST segment elevation in this case. And basically in this case, fibrinolysis and management is usually like that. Okay, so where there is a thrombolysis is done in management, or antithrombotic therapy is being given to the patients. And antithrombotic means there is like a thrombus formation tendency which has to be reduced, or which has to be prevented by the antithrombotic therapies or antithrombotic drugs. Okay, and talking about thrombolysis, where already formed clots in the blood needs to be lysed. So in those cases, that is thrombolysis. And thrombolysis and antithrombotic, both these management needs to be done in these cases, and that is the part of the management. And again, after that, the clinically, like findings in ECG, what all we see. So as I have talked about it, that ST segment elevation is seen, but in fully infarct and fully evolved cases, we are not able to see the ST segment elevation because it's just as a normal ECG, but only we can appreciate the pathological Q wave, which is significant of the or you can just by seeing the Q waves only, we can think about that there has been a condition or previously the MI attack has been there. So with that we can see, but there is no ST segment elevation in fully evolved cases and in old infarct cases. Plus, there is this T wave inversion. So there is this T wave inversion also, which is seen in fully evolved cases of MI. So in fully evolved cases, we can see T wave inversion also. Okay, and again, so this was all about MI, and there are various questions, especially in medicine, which are being asked regularly in MI, and one is like which is a common form, which is the common MI which is seen, that is anterior wall MI, which is the commonest, and also I just want to discuss about this see through anterior and lateral. Okay, so you can understand that I'm talking about septal here, anterior wall MI and lateral MI. Now, in what all leads you can see the septal MI. So it's V1, V2, and then interior V3, V4, and in lateral V5, V6. If we say that there is an anterolateral kind of an MI, then V3 to V6 will be seeing the ST segment elevation. Okay, in septal MI, if the MI is anteroseptal MI, then we'll see the changes in leads V1 to V4. Like that, you can remember with this mnemonic, see through anterior and lateral. And also, again in inferior wall MI, it is very important and regularly being asked. So there is this inferior wall MI. Okay, so in inferior wall MI you can see this I and F in it, so add one more pillar to this I, second and third lead, and AVF. So you can see the changes in these three leads in inferior wall MI, and after that there's this lateral wall MI, and this you can see the changes in AVL, that is with the letter L, and you can also see, as we have talked about, see through interior and lateral, and we very well know that this is V5 and V6. We'll also be seeing the changes in AVL, V5 and V6. Okay, and also in lead 1. Okay, and so these questions are being regularly asked. So this is one question which is not correct about dilated cardiomyopathy, and there are a lot of options here. So we know that in dilated cardiomyopathy we see the pulse is dichrotic, that is one peak you will be seeing in the systole and the other in the diastole. And in dilated cardiomyopathies, okay, first, what actually happens in dilated cardiomyopathy? The heart chambers are fully dilated, okay, and in this condition what happens, these walls also get dilated. Okay, the valvular, the annulus, that is the tricuspid wall, and that is the mitral wall, they also get dilated and relaxed, due to which what happens is there is this tricuspid regurgitation and mitral regurgitation, and the blood is also accumulating in that chambers because the heart walls are getting dilated, they're fully dilated, especially the ventricle and atria. So in this condition, what happens is there is also, this is one condition. The second is what kind of a murmur we usually see in this dilated cardiomyopathy. So we know that S1, S2, and S1. So this is a pan-systolic kind of a murmur which you see in dilated cardiomyopathy, not the diastolic one, but it is the systolic one. The murmur is systolic, and you can see that in the whole timeline between the S1 and S2 sound being heard, in the whole systole period, this murmur is heard, okay, in DCM cases. And again, there is a hypertrophy of myocytes, yes, and there is also a sudden cardiac death, which is a holiday heart syndrome, which is seen in people, and especially in alcoholic people, whereby you can see that there is an atrial fibrillation which is developing after this, and due to which there is a sudden cardiac death in patients of DCM. So they are also like when after detecting the TCM, they also do this implant, this device, that is cardioverter defibrillator, which is being implanted so that the defibrillation can be done with this instrument regularly, because there are a lot of chances that sudden cardiac arrest or sudden asystole can be happened, it is a possibility that it happens in DCM. And there are like, because in order to just prevent that, this is implanted in patients of DCM. And there is also this hypertrophy of myocytes which is there in DCM. Also it is seen in HCM cases, that is hypertrophy cardiomyopathy, hypertrophic cardiomyopathy cases, okay, but that pattern is the random kind of a pattern, that is also known as helter-skelter appearance, in especially in cases of HCM. In dilated cardiomyopathy also there is an hypertrophy of myocytes, and due to which there is an appearance, there is this pathological finding in DCM, that is also known as this ninja nerd kind of a nucleus, which is seen in DCM cases. And there is also